Okay. So, hello, good afternoon. Thank you all so much for joining us for Kidney Connections. I am Rachel DePaul. I'm the Vice President of Programs at the National Kidney Foundation of Illinois, and we're just really pleased to have you join us for this final webinar of the year. Next slide, please. So, the mission of the National Kidney Foundation of Illinois is to improve the health and well-being of people at risk for or affected by kidney disease through prevention, education, and empowerment. So this program today is just an awesome way to really work with our mission as well. Go ahead, next slide. We'd also like to thank our sponsors, Fresenius Kidney Care, UI Health, and Northwestern Medicine. You'll be hearing a little bit more from them throughout today. And we just encourage you to follow us if you're on social media, to follow us on any of our social media channels. And we also encourage you to listen to our podcast, The Journey Continues, wherever you listen to podcasts. It's a really great podcast that just shares some really critical information about powerful organ donation stories. So now we are going to talk about today. So we have some really great presentations for you, but then we also have a really great panel discussion for you today. So our panel discussion is going to be facilitated by Dr. Kowalski. He's a board-certified interventional nephrologist and assistant clinical professor of medicine at Loyola University Stritch School of Medicine, and he has over 7 years of clinical and academic experience. His expertise includes interventional procedures, hypertension, and cardiorenal metabolic inflammatory sarcopenic spectrum of disease. He has received multiple teaching awards and is well known for his commitment to medical education. He is also the founder of Kidney Strong, a patient education platform dedicated to raising awareness and preventing chronic kidney disease. And his upcoming book will further reflect his passion for CKD prevention and improving kidney health outcomes. And now I'm so pleased to introduce our panelists. And the first person you'll be hearing from today is Dr. Obaidi, and she is a clinical academic nephrologist and assistant professor of medicine at the University of Chicago. She earned her medical degree from the University of Sharjah in 2011, then completed her internal medicine residency at Southern Illinois University in 2018. She then pursued an academic hospitalist fellowship at Johns Hopkins, followed by a 2-year fellowship in nephrology at the Johns Hopkins Hospital. Her academic work has been focused on clinical excellence and bedside teaching and clinical interest in thrombotic microangiopathies and glomerular diseases. She enjoys teaching and has been recognized for her teaching skills among residents and fellows by winning several teaching awards. We also have Jackie Henkins, who is a registered dietitian at Rush University Medical Center in the section of nephrology and hypertension, transplant, and cardiology. She also serves as a nutrition consultant at Sanderling Dialysis. Jackie is board certified specialist in renal nutrition, holds a faculty position at Rush in the Department of Clinical Nutrition, and serves on the professional advisory board for the NKFI. She provides outpatient nutrition education and counseling to patients with chronic kidney disease, patients on dialysis, and those pursuing kidney transplantation. Jackie is an amazing volunteer for NKFI for a variety of our programs and is an active member of the renal practice group of the Academy of Nutrition and Dietetics and serves as the lead editor for their peer-reviewed publication, Renal Nutrition Forum. And we also have Nadia Payne, who is a stage 3 kidney disease patient, and she has also maintained at stage 3 for 10 years by making significant diet and lifestyle changes. In addition, she is also a type 2 diabetic and has been off insulin for 2 years. I'm also going to plug that she is one of our amazing facilitators for our Take Charge program. And while her journey hasn't been easy, her health is so important to her. So as we move forward, we're going to encourage you to save the date. We do have our Big Ask, Big Give program coming up on Saturday, November 22nd in partnership with UI Health. And Big Ask, Big Give really teaches you how to make the ask for and share your story to find a living donor. So we talk about myth busting, we teach different strategies. It's a really great program and we'd encourage you all to join. You can register today at our website or by taking a picture of the QR code that's on the screen. And finally, before we turn it over, Just a bit of housekeeping notes. So, as we go through the webinar today, if you'd like to ask any questions during the panel discussion, make sure that you are using the chat button or the Q&A, and we will make sure to get to those questions. So, I am going to go ahead and turn it over now to Dr. Obaidi.
All right, thank you so much for the kind introduction. This is Zainab Abaidi. I'm an academic nephrologist at UChicago and really happy to be here. So I'll just go ahead and share my slides. Let me see. All right. Do you guys see the slides?
We do.
Okay, excellent. So today I am going to talk a little bit about nutrition and chronic kidney disease. Before I start, I do have to mention my disclosures. I am a consultant and work in advisory boards for several therapeutics, but none of them are involved in today's talk, mainly with IgA nephropathy. And so the objectives for today's session is really to outline key dietary recommendations in chronic kidney disease or CKD when it comes to protein intake, sodium intake, and potassium. Again, we can expand on that in the panel discussion later today, but just wanted to bring some updated guidelines when it comes to these topics. And then also review current medications that are approved for chronic kidney disease care moving forward. And again, just for housekeeping, if you do have any questions, please feel free to type it in the chat or reserve it towards the end of the presentation. And so, when we start off, why do we worry about chronic kidney disease and why does it matter? And it's because really the burden of disease is pretty big. So 1 in every 7th adult in the United States has chronic kidney disease. That's probably undiagnosed or underdiagnosed, and this affects about 30 million people. The main cause of chronic kidney disease in the United States is mainly high blood pressure and diabetes, which are both preventable causes that we're really trying to address early on in treatment. And again, the major health impact in these patients is really cardiovascular disease, and this is the major cause of mortality in these patients. And the economic burden, again, Medicare pays about $98 billion annually for all kidney disease stages. So again, the burden of disease is definitely there. And so, when it comes to nutrition and obesity, what do we really mean by obesity? And so this is a question that's always asked by our patients as to what does that mean? And traditionally, we've always used the BMI to estimate. And what BMI is really, it's your weight in kilograms divided by your height in meters square, and basically plots it according to a population distribution of body weights and heights. And it kind of spits out a number to us that tells us in what range do you fall. Usually for normal weights, it's anywhere between the BMI of 18 to 24. means that you're good. But as that number goes up, specifically above 30, then this is when patients are labeled as obese. There are currently other ways to diagnose obesity by impedance testing and by other means, but in general, BMI has been adopted widely and it's easy to use in clinic. And so usually when we counsel patients for obesity, we look at the BMI as a rough estimate to kind of frame the conversation moving forward. And so why does obesity happen and how is it related to kidney disease? We don't really know the exact association, but it is believed that the more food that you take, that the ultra-processed diet, so that means, takeout food or heavy fatty meals, that usually causes a net gain in calories of about 500 or more of your total daily. And then that leads to a 1 kilogram weight gain versus if you eat unprocessed diet, which are like unprocessed food and vegetables, that usually leads to 500 less or fewer calories, and that actually leads into a net weight loss. And so, with our population aging, and again, with limited resources for food, a lot of people are resorting to fast food, which is creating this pandemic of obesity and being overweight even at a younger age. Which leads to visceral fat accumulation. So what visceral fat means is that when you have fat depositing around not only in the skin, but also deposits around the wall of your heart, your stomach and liver. And this visceral fat is actually tied to higher risk of death because it's just affecting these organs internally too. And so what are we doing about it? So really we're trying to target fat loss, which is the equation of calories in. So we're trying to minimize calories in minus the calories out. And this deficit of, we're trying to have a deficit of at least 500 calories a day to start with so that you can lose more than you're getting in as far as calories. And so when it comes to the renal diet or the kidney diet, what it is really is it's actually optimizing specific nutrients to reduce the workload on your kidney. And so what are some of the key nutrients that we usually watch for? This is sodium that we're going to talk about because it affects your blood pressure and your fluid balance. Potassium, which really plays a pivotal role in maintaining the rhythm of your heart. So it's really important to monitor that. Phosphate levels, which are also present in a lot of our food items. And so how do we monitor that? And protein intake, which again, we all, in our balanced American diets, we do incorporate protein. So again, what is a sweet balance in our chronic kidney disease population? And so again, each patient is different. So that's why we do recommend talking to your nephrologist or a certified dietitian because your dietary plan will be individualized to you, to your chronic kidney disease stage, according to your lab results and to your other health conditions that you may have. And so when it comes to salt, right, this is one of our most asked questions in clinic as to, doctor, how much salt do I need to intake? And so we actually have updated kidney health guidelines, which are known as KDIGO, that released updated guidelines in 2024 that I will be referring to throughout the topic and the presentation today. And what they recommended is basically limiting the sodium intake in chronic kidney disease patients to less than 2 grams per day. And sometimes if you're not aware of sodium, you're more familiar with sodium chloride because that's more present in labels and everything, then that should be limited to less than 5 grams of sodium chloride per day. And so why do we worry about salt? It's really because salt is tied to your water. So salt and water are best friends. And if you eat more salt, it's going to pull more water into your blood vessels, and that can sometimes elevate the blood pressure. And so patients who have pre-existing blood pressure problems, if they do have a lot more salt, then the blood pressure can go high, which makes us want to add more medications when the cause is really, dietary related. And so, we actually encourage patients. I also read labels all the time when I'm in grocery shopping. So I developed this habit of reading nutrition labels. Always flip the items that you're reading. Look at the serving size. How big is that? Is that 1 cup or 2 cups per serving size? Because the label reflects the serving size that you're getting. And always focus on sodium. If it's, in this example, it's 27% of your total daily value, which could be fine for a normal adult, but if you have chronic kidney disease, then we usually aim for less than 5% of your total daily requirement. And also, if you look at the milligrams, usually we should aim for less than 150 milligrams in sodium, which is considered a low sodium, and anything above 400 milligrams is considered high in sodium. So just try to do that, quick math when you're grocery shopping to optimize the items that you're getting at home. And so what are some tips to reduce salt intake? So this, as we mentioned, is make it a habit to read the nutrition fact labels. Prepare your own food at home because you know what you're adding to it when it comes to salt and other elements to it. Add flavors without adding sodium. So there's a lot of other herbal supplements that we can, and I'll talk to you a little bit about as to still add some flavor, but not necessarily salty. And actually replace your food with fresh produce. Fresh produce has less, preservatives, and that really cuts back on salt because salt is one of the biggest preservatives, especially in canned food items. And so maybe buy fresh produce. Watch your vegetables, buy fresh if possible, avoid any canned food items because of the preservatives, as we mentioned. Always give it a rinse whether you're washing your vegetables, especially canned food items. Always make sure that you wash them if you do decide to buy that. Always pick unsalted snacks for your options, whether you have the salted cashews or something, maybe go for the unsalted option. And consider condiments, reduce your portion sizes if possible, and make lower sodium choices at restaurants. So instead of ordering like a heavy pasta meal, maybe supplement that with a salad that you can control the dressing and have the dressing on the side. That way you're also knowing what you're getting as far as salt intake. And so there's also been a notion of using other diets that have been clinically proven to be useful. So the DASH diet. And I'm not sure if you're familiar with it, but it's actually an acronym based on the Dietary Approaches to Stop Hypertension. And it's been initially developed for people with high blood pressure. And what it is basically, it's a heart healthy eating plan to lower blood pressure and support kidney function in patients with high blood pressure. And really, it focuses on fluids and vegetables, eating whole grains, which have high amount of fiber, low fat dairy products, and lean proteins such as fish, chicken, and beans. And it really focuses on limiting sodium intake, added sugars, or saturated fats in these patients. What about protein intake? Again, one of the biggest questions asked in clinic. And again, based on our guidelines, it really debunks this theory that we should restrict protein in our chronic kidney disease patients. We do recommend, per the KDIGO guidelines, to limit protein intake to less than 0.8 grams per kilo per day. And if you want to have like a better estimate of that mean, so here's, for example, body weights in kilos. So for the average person, if you weigh 70 kilos, then that means if you do this math, then it's about 56 grams of protein. And I don't know about you, but 56 grams of protein is a lot. I surely don't eat that much, but it basically tells you that you have a wide range of protein intake that you should be able to eat freely without being worried about excess protein amounts. Now, why is there a concern with protein in chronic kidney disease? Because when you ingest protein, a lot of that protein is converted into the urea cycle, which can add more toxins and makes it harder for your kidney to excrete that. The other thing is when you eat a lot of red meats and processed meats, it generates a lot of acid in your blood. And when acid is produced, then your kidney has to generate ammonia to excrete that acid, to package it in a way to excrete it in the urine. And that leads to increased ammonia formation, which, as you can see, Homer Simpson in here, he's like, ammonia is great for cleaning, but it's bad for your brain. Because if you do have excess amount of ammonia, with the more severe stages of chronic kidney disease, then that can go into the brain and cause more confusion. And sometimes we do have to dialyze patients for confusion and uremic symptoms. So this is, again, in extreme cases. I'm not saying that that's in every patient. Having said that, we really want to optimize protein intake in our patients, specifically if they're elderly, if it's a 60 or a 70 or an 80-year-old gentleman or a woman who does not eat much and they're at risk of being malnourished, then we always recommend, by all means, please optimize protein intake because the last thing we want is to restrict protein intake. And these patients can become frail and they can fall and break a hip, and that would actually lead to their death more so than a chronic kidney disease related to protein intake. So we always customize and are very careful about limiting protein intake for that reason. Because again, most of our chronic kidney disease patients are more on the older side, they're more malnourished. So we really spend a lot of time counseling them to eat appropriate protein without being fearful of eating too much. And actually, in patients who are more malnourished, KDIGO guidelines recommends going up to even more than 0.8. You can go up to 1.3 grams per kilo per day to optimize nutrition in some patients. Now, what about patients who are healthier, who are not as frail? Then, there's always this push of trying plant-based proteins versus animal proteins, and there has been small amount of studies or looking at the benefits of plant-based proteins versus animal-based proteins. And currently, the theory is that plant-based proteins are better because, again, they don't stress your kidney as much. The acid load is less, and so you're more likely to have a balanced pH in your body. And so what are plant-based proteins? Things like legumes, dried beans, nuts and seeds, whole grains and cereals, starchy vegetables and bread, versus the animal proteins are the red meats, the fish, poultry, eggs, the milk and cheese, and so forth. And so, it just, these studies looked at kidney function and they did see that when you eat more cleaner diet or plant-based proteins, your kidney blood flow is less. The stressor is less on the kidney. It's not working as hard versus with animal or red meats, then the blood supply to your kidney is working harder. It's 30% more active to try and kind of counteract or oppose this acidity that's generated from the animal protein. And so technically, that decreases demand on the kidney if you do opt for the plant-based protein option. And so, which food products have protein? So, poultry, as we discussed, meat products, whether they're lamb or roast beef, dairy products such as cheese and yogurt and eggs. Fish also has a lot of protein in it. So, these are all common protein-containing food items. So, again, what should we do? We kind of counsel patients to eat a healthy meal. And what is a healthy meal? So, technically, the easiest way to visualize it is if you have a plate. Half of that plate should be vegetable based, and then a quarter of it should be carbohydrates, such as potatoes, sweet potatoes, oats, and then the quarter of it should be proteins, whether they're animal-based proteins such as turkey, eggs, shrimp, or tofu, beans, lentils, if it's plant-based. And I know that Thanksgiving is coming through in the next couple of weeks, so do be mindful about how you're portioning your plate, especially that turkey has a lot of salt in it. So maybe opt for smaller samples or less salt seasoning when doing that. And so again, looking at eating more vegetables, what does that mean in this balanced meal that we're talking about? So fill up half your plate. This could be the goal of achieving 5 or more servings per day of any fruits or vegetables. One serving of vegetable is about half a cup of cooked, veggies, or 1 cup of raw cooked veggies, or 2 cups of leafy greens because they tend to take more space. What about proteins, right? So proteins should be about 3 to 4 ounces, and it's around the size of a deck of cards. So you can see in this image in the bottom left-hand section, so animal-based proteins should be about the size of the palm of your hand. But for example, for plant-based proteins, it's half a cup is about a clenched fist. So again, if you're not sure about how much protein, whether it's plant-based or animal-based, you can use your hand for the animal-based and also a clenched fist if you're using vegetables for the plant-based to help you estimate that. And again, focus when it comes to proteins, it's all about portions, right? So focused on minimally processed proteins. Think about poultry, eggs, and the fresher the better because if they're refrigerated or frozen, then they may have some preservatives. So try to get them as fresh as possible. And again, add more plant-based proteins to your diet. So whether it's beans or legumes or tofu, feel free to try different things and see what works for you to supplement some of that protein intake and reduce the burden on your kidney function. What about carbs, right? So again, carbs should take a quarter of that plate, and we're talking about half a cup of serving size. It could be of whole grain bread, brown rice, oatmeal, quinoa, or potatoes. And we usually try to shy away from any white bread or white rice or white pasta because of that high content of cornstarch that again has a high glycemic index and increases risk of obesity and diabetes. What about potassium? So potassium is also one of the things that we closely monitor in patients with advanced chronic kidney disease. And according to our guidelines with KDIGO, they do mention that we should limit potassium-rich food items, specifically in patients with chronic kidney disease stage 3 through 5, which are basically patients that have kidney GFR of about 60% down to less than 5%. So in that disease population of patients, we do keep a close eye on potassium. And why is that? It's because about 80 to 9% of potassium is excreted by your kidney. So you can imagine as kidney function declines to 5 or 10%, then potassium tends to build up in our body. And you may ask, well, what's the big deal? Why do I care about potassium? Well, the thing is, potassium, your heart is bathed in potassium and it's very sensitive. So the heart contractility is highly dependent on potassium. And if the potassium drops too low or goes too high, that can throw the heart into a lethal rhythm. And as we mentioned in our chronic kidney disease patients, the highest risk of death is usually cardiovascular. So we really want to optimize heart function. And the last thing we want is someone to die from uncontrolled potassium levels, whether it's from medications or a combination of that and the diet. So this is something that we worry about mainly because, again, potassium is mainly excreted by the kidney, and if it builds up, it can affect the heart, throw it into a lethal rhythm, and that could be a preventable cause of death. And so what do we mean by potassium in the diet? So potassium additives. So usually potassium is not naturally abundantly present in food, but it's usually often added to processed foods as salt substitutes or preservatives. So again, we go back to reading labels, right? So you could see here, for example, they may not mention potassium per se in the main items, but if you look at the fine print, they always mention something like potassium lactate or potassium iodide, or there's always the fine print. So always make sure that you also read ingredients, because if they do have some potassium in it and you have end stage or chronic kidney disease, then you have to be careful about how much potassium you're taking in. The prevalence in food supply is growing, so now we do see more potassium in added to food products, unfortunately. So always read ingredients list. This was actually a label from a pre-cooked chicken breast, so you wouldn't think that, but even in processed meats or frozen meat samples, we always see those as additives that are being added, and it does not necessarily reflect in the reading label itself. And so again, when it comes to potassium, be cautious. We do have natural sources of potassium, whether it's bananas, potatoes, tomatoes, broccoli, avocados. I had a patient who was eating watermelon, like a whole watermelon a day during the summer, which has a huge amount of potassium. So if you're not sure, I think Google is your best friend. You could just type in, is this whatever you're eating, does it have a high potassium? And if it does, then that's your cue to maybe supplement with something else. Even in salts currently, like Morton salts, which is something we use a lot, it contains potassium chloride. So again, it has about 40% of potassium chloride. So again, if you're using salt, which again, you should be limiting to less than 2 grams a day, make sure that your salt does not have any additives such as potassium, which could exacerbate your condition with advanced chronic kidney disease. So what do you do? And I know this sounds like it's limiting and frustrating, but we have a lot of other supplements that I personally find very tasteful. Some things like basil, oregano, cinnamon, cumin, curry powder, nutmeg. I mean, there's so many things you can use that would give you just as much flavor without resorting to salt, when cooking. So this was a wrap up of the dietary recommendations based on our guidelines. And again, we didn't go into everything, but we will be happy to answer more in the panel discussion. What I really wanted to take time to focus on for this talk is also medications in preventing delay and preventing and the progression of chronic kidney disease patients. So what are the current medications that we're currently offering our patients? And where is that data coming from? And what are some of the side effects and benefits of these medications? And so, when it comes to goals in chronic kidney disease, why does it matter? Because we really, as nephrologists, we want to delay progression of chronic kidney disease as much as possible. And why is that? Because we want to prevent death from heart or kidney-related problems in our patients. And so what are some of the goals that we look for is blood pressure control, making sure that the target blood pressure, the top number is below 120, the bottom number is below 80 based on our guidelines as much as possible. If we can achieve that goal, that would be ideal. Obviously, if someone is elderly, like we mentioned, and they cannot tolerate pressures that low because their body is used to higher pressures, then obviously safety is key. We're not going to push because some patients do get dizzy or lightheaded if we put them on a lot of medications. But ideally, as much as possible, if we can, we should aim for 120 over 80 as far as blood pressure goals. When it comes to sugar controls for diabetic, we also aim for A1Cs that are below 7% to 6.5%. And again, in elderly who cannot tolerate that because of symptoms, we usually aim for higher A1C. So again, these numbers really depend on our patients that we're seeing. Obesity, maintaining healthy body weight through diet and activity is important because if you control and lose only 5% of your total body weight, that can drop the blood pressure by about 5 points. It can reduce your risk of diabetes, and we can actually take some of these medications off just by losing 5% of your total body weight. Cholesterol management, again, is something we usually check annually for our chronic kidney disease patients to make sure that the cholesterol is not building up, which again can affect the heart function. So we do optimize heart risk factors in addition to kidney risk factors to make sure that, all these angles have been looked at. And then again, the long-term benefits that we're really trying to achieve is to slow kidney function decline and reduce the risk of heart disease and stroke in our patients who are more vulnerable to that than the average healthy patient. And so, this was actually revolutionary for us in nephrology. Now we do have four pillars of goal-directed management therapy for type 2 diabetics with chronic kidney disease. It may sound like a handful, but what it basically means, based on recent trials that have been accrued through the past 10 years, we now have evidence to support that in patients with diabetes and chronic kidney disease, some medications should be cornerstones to therapy because these medications have been shown to either prolong expectancy of the patient or even reduce heart-related deaths or reduce kidney-related deaths. So these medications actually have mortality benefit, which is why we really try as much as possible within the safety profile to put most of our patients on at least two or three of these medications as tolerated to really buy them longer lifespans and also prevent heart-related deaths from occurring. So we're going to talk about each one of these medications and to review the literature with that too. So the first one is the renin-angiotensin system inhibitors, or RASI inhibitors, or the angiotensin receptor blockers, which are also known as ARBs. And so per our guidelines, we would initiate ACE inhibitors or ARBs at maximally tolerated doses in patients with diabetes or without diabetes with protein in the urine. So, these medications are our first line, our go-to. Even if you don't have high blood pressure, we usually like to keep these medications on board, not only to reduce blood pressure, but to also lower diabetes-related risks and also reduce the protein level in the urine. Because in chronic kidney disease, we have two markers that kind of tell us how fast your kidneys will decline. One is the GFR, which is the percentage of blood flow going to your kidney. And then the other one is the proteinuria, which is the protein in the urine. And so the more protein you spill in the urine, it kind of gives us an idea that the kidney function decline will be faster. It's like pushing on the gas pedal that your kidneys will decline faster than someone who has no protein in their urine. And the analogy that we usually use is that, you can imagine your kidney as a coffee machine, that you have a coffee filter and you filter coffee. Well, imagine if you poke holes in that coffee filter, then what happens to the coffee beans? They seep through, right? And you never want coffee beans in your coffee. That's just not right. And so the same thing with your kidneys. If you poke holes in your kidney filter, whether it's diabetes, high blood pressure, medications that hurt it, or, other conditions like heart failure, then the protein, which is meant to be in your body and blood, starts seeping through and leaking into your urine, which we never want to see. And so our goal is by adding the ACE inhibitors or ARBs or the MRAs or the SGLT2s is to really protect that kidney filter and repair it to cut back on this protein loss that we're seeing in the urine. So we do layer these medications with the aim of repairing that kidney filter as much as possible. And so again, when it comes to ACE inhibitors or ARBs, we do try to increase these doses as much as we can because of, again, that added mortality benefit and cutting the protein in the urine, which would decrease the kidney decline. And we also use it in patients who have chronic kidney disease and heart failure, or if they have chronic kidney disease with high blood pressure, because again, in these patient populations, it's also been shown to be really beneficial in prolonging life expectancy when it comes to these patients. What about sodium glucose cotransporter 2 inhibitors, which are known as SGLT2 inhibitors, which you may have seen in the advertisements such as Farxiga, Jardiance, or the trade names such as dapagliflozin or empagliflozin. And so these are also been, a while in the market. And again, these are one of the few medications that reduces the risk of dying from heart or kidney disease. And again, we don't have a lot of these medications in nephrology, but ACE inhibitors, ARBs, and the SGLT2s have been shown to reduce the risk of dying from heart and kidney disease. And that's why us as nephrologists, we love using them because of that added benefit. And so when do we use SGLT2 inhibitors? Again, according to our guidelines, we do initiate it in diabetics with chronic kidney disease that still have protein in the urine despite ACE inhibitors or ARBs. If they still have protein, then we add that next medication to see if it helps repair that kidney filter. And so how do SGLT2 inhibitors work really? So the way it works is that SGLT2 inhibitors, they act in a like in a part of your kidney that forces sugar to be peed out. And so this really helps in diabetics and also in non-diabetics. And it also turns on some of your genes that simulate fasting. So your body then is forced to break down other sources of stored fat, which is why it leads to some weight loss and also in mortality benefits. So it has a very interesting mechanism of action. And so the benefits of that is, by simulating this fasting state in your body by turning on these genes, the blood pressure goes down, the glucose level decreases, you start having some weight loss because again, you're breaking down other sources of fat in your body and glycogen stores. Patients have also reduced risk of heart failure because your body is working less. There's also decreased mortality, which means death from any cause, including heart-related deaths, which is the MACE. Also decreases the decline of your chronic kidney disease progression, which is what we love to see, and also decreases risk of acute kidney injury or damage to your kidney. Now, just like any medication, these medications do have side effects, some of them being genital infections. So for me, for example, when I have a patient that I'm starting on SGLTs, I always ask, did you have a history of genital, like of candida, like yeast, urine tract infections? Because if you do, then maybe this is not the medication for you. Because like we mentioned, SGLT2 inhibitors, they force, force your kidneys to pee out sugar in the urine. So you can imagine the urine becomes very sweet, and this is a perfect fertile ground for candida and used to thrive with. So if someone has a history of, candidal UTIs, then we're not going to make it worse by adding SGLT2 inhibitors. So usually that's something we reserve not starting SGLTs. Patients who are dehydrated, because again, SGLT2 inhibitors makes you pee out a lot of sugar water. And so if they're dehydrated, then maybe not. Also increases risk of urine tract infections, specifically the candidal infections that we spoke about, along with other things that we also keep in mind. But again, sometimes the benefits outweigh the risks, and we usually follow these patients closely, make sure that they're tolerating the dose, and we usually slowly increase the doses as tolerated. So it's not like we started and we just forget about it. And so the next class of medications are the MRAs, which are the non-steroidal mineralocorticoid receptor antagonists, which again is a handful, but they're also known as finerenone or MRAs. These are also a new class of medications that were developed for diabetic patients that have persistent protein in the urine despite adding ACE inhibitors, despite adding SGLT2s. If you still have protein in the urine, then finerenone or these MRAs are the next class of medication, again, providing that protection to the kidney filter. And so our guidelines tell us, initiate MRAs in diabetics with persistent protein in the urine. Granted, the GFR or the kidney function should be above 20% because finerenone hasn't been used in patients who have really reduced GFR. But granted, if they have good kidney function up to CKD stage 4, then we usually use it. And specifically, even if patients have like heart failure, then that's even more so reason to start it in these patients. Why? And that's because, finerenone in studies has been shown to reduce the risk of being hospitalized from heart failure by about 22% or 1/5 of the patients. So why not, right? Why not add this medication to reduce risk of hospitalization and protection from future heart failure exacerbations in our already vulnerable chronic kidney disease population? And so again, what are the pros and cons of MRAs? As I told you, the pros is that it reduces heart failure risk in the future in our already threatened, vulnerable chronic kidney disease population. But the cons, it's a blood pressure medication, so it can drop blood pressure in some of our patients, which is why we tell them to watch their levels very closely. And if they drop or they feel dizzy, then they should tell us. And you usually start with very low doses to see how they can tolerate and slowly go up on it. Again, there's also risk of hyperkalemia, although that is a lower risk than other medications that we do start, like spironolactone. In about 10% of patients, they may have a mild elevation in potassium, but that elevation does not usually stop us from holding does not stop us from treating these patients with finerenone. We still treat them, but granted that the potassium is within acceptable levels. And then sometimes it can also, initially, when starting finerenone, your kidney is not used to it. It can sometimes cause kidney injury in the beginning, but then your body gets used to it and then the kidney levels improve. So these are some of the side effects of finerenone. But again, we start with low doses. We watch closely by repeating blood work in 2 to 4 weeks to make sure that the kidney is responding appropriately and the patient's doing well with it. And finally, we're going to talk about the glucagon-like peptide receptor agonists, which again is a handful, GLP-1s, which are also known as Ozempic, Wegovy, so many different trade names that we have, which are the weight loss medications. And again, our guidelines in 2024 did recommend starting it for our CKD patients who have diabetes, or the ones who are having problems controlling their diabetes with current diabetic medications such as metformin or SGLT2s, and it's not working, they cannot tolerate it, they still have protein in the urine, then what do we do? Then GLP-1s have actually been shown to have so many positive outcomes in our chronic kidney disease population. And so, what do GLP-1 agonists really do? And so, what it does, you can see in the blue section of this picture, you can see that they make you pee more, basically. They decrease oxidative stress, which is something, we worry about. This is what causes tissue injury and kidney decline when you have a lot of oxidative stress in your body. But GLP-1s actually finds a way to reduce that stress in your body. And it also reduces atherosclerosis and inflammation. Atherosclerosis basically means, the hardening of the blood vessels in your heart. And so it reduces that risk. And again, as I told you, chronic kidney disease patients have a high risk of heart disease problems. So this actually melts away some of the deposited cholesterol in these blood vessels, which is great. And so as a result of these direct mechanisms, indirectly, it causes weight loss, it controls blood pressure better, and also controls glucose or sugar levels better. So actually, one of the biggest trial was the FLOW trial that I have mentioned here. The FLOW trial enrolled about 2,000 patients that some of them had chronic kidney disease stage 3, about 60 to 70% had that, and a lot of them had diabetic kidneys. So these were in our CKD population with diabetic kidney disease, and they looked at their outcomes. They looked at these 2,000 patients to see, how was their survival when it comes to kidney function. And interestingly, it did show that it did decrease heart-related events by about 28%. It caused the protein in the urine reduction by about 38%. It reduced proteinuria in the urine, which is excellent. It caused 29% lower risk of heart-related deaths, which is, again, something we really want for our CKD population. It caused, on average, about 4 kilos of weight loss in some of our CKD patients. It reduced the A1C, which is a marker of diabetic control, by about 1% in most patients, and also caused blood pressure reduction. So you can see all these are positive effects that we really try to optimize our patients, and clearly it has been working well. And so one of the major side effects, though, has been GI side effects, which occurred in about 13% of our patients, because what GLP-1 agonists do is that it really slows down the GI tract. So you can see that instead of like being pretty active and eating all the time, it really slows down the rhythm of the GI tract. So a lot of times these patients complain of bloating, being full, sometimes feeling nauseous. So the GI side effects have been reported, but I think after some time or reducing the dose, the body kind of gets used to it that at a certain dose, and sometimes patients really do not tolerate it, which makes you stop it. But about 13% of patients usually do experience GI side effects, specifically constipation, because again, that slower transit time, which we sometimes can give laxatives such as Miralax to help with that. And so, what are some key takeaways from today's talk? I hope that I did convey that chronic kidney disease requires a multidisciplinary approach with diet control, optimizing blood pressure, and diabetes. Dietary control is challenging. We do know that, and we sympathize with that, but you can always consult with a nephrologist or a certified dietitian to help tailor, these dietary recommendations to your needs and your day-to-day activities. We do recommend discussing medications such as ACE inhibitors, SGLT2s, MRAs, the GLP-1s that we talked about with your nephrologist to see if you qualify and if it's still safe for you to take those medications because of their significant mortality benefits and heart protection and kidney protection qualities. And again, prevention is key. So whether that's by exercising, by controlling and eating healthy to prevent any future kidney or, for future blood pressure or diabetic kidney disease is obviously the key to slowing down kidney disease progression in most patients. And with that, I would like to thank you all for listening and happy to take any questions. Thank you so much.
Thank you so much for that wonderful presentation. We will be doing a couple of words from our sponsors and then we'll be jumping into our panel. So at this time, I'd like to welcome Fresenius to present their information. So Arbani, if you want to jump on, we will go ahead and have you join us.
Thank you.
Thank you.
All right. Hello. My name is Arbane Davis, and I'm a kidney care advocate for Fresenius Kidney Care. I work within the Illinois region with several other kidney care advocates to maintain the area for education. So our job is to educate patients as well as their families on various treatment options for renal therapy. However, our classes are also available for anyone who would like information on kidney disease. So we offer a variation of classes to accommodate the different needs and preferences, providing both in-person and virtual classes with a live educator like myself. Next slide, please. So all of our education courses are free and they are available for not only patients, but family members and care partners as well. This is a great opportunity, especially for those families who would want more education, but maybe the patient is a little reluctant on hearing the information individually. Within the class, patients will learn various things about kidney disease that goes along with their signs and symptoms, treatment options, types of accesses, and even dietary resources to promote the reduction of contributing factors in the body, such as potassium and phosphorus. Next slide, please. You can also register for a virtual course by scanning the QR code below. We also have those courses in English or Spanish speaking classes. And you can also submit questions by sending them to kcve@freseniusmedicalcare.com. We have some great virtual educators. Their names are Tina and Ernesto, and they are equally amazing. So we do have some various options for those different preferences. Next slide, please. We also have a peer-to-peer program that is also virtual for patients, but it's hosted by our patient consultant. His name is Sam Trevino. Sam is a person who has experienced the various renal modalities with his wife as a care partner. So Sam is a great resource for others and their families to help navigate through those questions and concerns that a person may have from a person within the community. Next slide, please. So yes, when booking a virtual appointment, the website will look like this. It'll give you various options for the various courses that we offer, both CKD as well as ESRD. And you just simply enter your information in the form boxes and click submit for the courses that you selected to be booked. After doing so, you will receive an email shortly confirming the selected date and time. Next slide, please. So upon doing that booking, the website will send various reminders before and after the course. So just reminders so that way you know at the time of the booking as well as the day before, along with various resources for the patients and for the family post-education, such as a virtual brochure, cookbook, and survey link. Go ahead. So lastly, after the education, persons have various resources for post-education for follow-up. If the patient is established with a nephrologist already, an education communication form will be sent to the physician for follow-up. But even if a person does not have an established nephrologist, all persons attending the course will also receive other helpful resources like our insurance coordinator, and as well as having a conversation with a local kidney care advocate like myself to follow up. So this will help aid in the ability for questions if they, may not think of it during the course, because it is a lot of information to retain. And with that, we have the ability to give so much information to our patients in various ways. So we're acting on our goal and mission by first providing exceptional information to aid in the ability for sound decisions for them within their healthcare. So we are meeting our patients where they are, whether there is in person with a handout or virtually online, as well as even with direct mail. So please feel free to share information with others and our resources, because they are not just for people that are experiencing renal failure. So again, my name is Arbonne Davis, and I'm a kidney care advocate for Fresenius Medical Care. So thank you for your time.
Thank you so much. I'd like to welcome Sharita Brown from Northwestern Medicine next.
Can you hear me okay?
We can. Thank you, Sharita.
Perfect. I'm gonna just share my screen. Does that look good on your end?
I'm not seeing your screen yet. No.
Oh, I'm sorry. Are you able to see me?
We can see you.
Can
We
you?
can't see, yeah, what you're trying to share yet, though. Oh, it's coming up right now.
You got it? Okay, sorry about that.
No, it's okay. Give it just another second.
Okay.
It's a little slow. There we go. It's up now.
Okay, perfect. Okay, I am Sharita. I'm one of the transplant nurse coordinators with Northwestern Transplant Program. So I just wanted to share briefly some of the things that we're really excited about here at Northwestern. We have one of the largest living and deceased donor kidney transplant programs here in the Chicagoland area. For diabetic patients, we also offer a pancreas transplant or simultaneous kidney transplant, where they do them together if a patient would qualify for that. We're very excited about some of the innovations that we are participating in here at Northwestern. One of those might include the use of biomarkers for our post-transplant patients, which is basically a non-invasive way to monitor the kidney to kind of look for early signs of rejection without the patient having to go for biopsy right at that time, which of course would help sustain the life of a recently transplanted kidney to help get that kidney to last a little bit longer. We also do a lot of work with immunosuppression, a lot of clinical trials and things like that for steroid-free immunosuppression, as well as immunosuppression-free transplant. We offer all of our donor surgeries as robotic or laparoscopic. Usually those donors are only need to stay in the hospital for 1 day. We also have something more recent, the await kidney transplant, which is for certain patients who it would be beneficial for the use of spinal anesthesia as opposed to general anesthesia for a transplant. I wanted to talk a little bit about our kidney paired donation. As I stated before, we are one of the largest kidney living donor programs in the nation, actually. We've completed more than 200 paired transplants. We've cared for donors and recipients over more than 20 states. And it's a really good program because it does help recipients who might be harder to find a match, more options or whatnot. We also have a program called Kidney Champion Program. It's a program designed to help patients find new ways to find their living donor. We always like to remind patients that a living donor does not need to be related to you. They don't need to be the same blood type as you. Just needs to be someone over the age of 18 who is fairly healthy and willing to donate, so that patients can kind of start thinking out the box when we're looking at living donor transplants. We also do a lot of outreach as well to bring transplant evaluations closer to the patients in their homes. or home areas in case they don't want to travel all the way downtown and pay for parking and things like that. So we have 9 outreach clinics, with the most recent one being opened in Bronzeville. In 2024, we did 343 kidney transplants. When we put all the organs together, solid organs together, kidney, liver, lung, heart, and pancreas, we did a total of almost 700, 691. So we are very, very proud of that. We always say if you need a kidney in Chicagoland, you're in a great place, because we do have so many centers, great centers, who offer this service, with Northwestern, again, like I stated, doing 343 last year. In addition to the volume that we have done, we also have really good quality. So as you can see, Northwestern's outcomes tend to surpass the national outcomes as well. We are very, very proud of the fact that we have transplanted over 10,000 patients with solid organ transplants as of 2025, so more than 10,000. So we are extremely proud of that. Rachel, do I have 2 minutes?
You do, Sharita.
Okay, thank you so much. We wanted to highlight the patient that we had who did the awake kidney transplant. Oh, sorry. All right. Thank you so much for giving us this opportunity.
Thank you so much for joining us, Sharita. And now I'm also pleased to welcome Blanca Contreras from UI Health to join us as well.
Hello, everyone. Please bear with me while I share my screen. Are you able to see my screen okay?
We are, thank you.
1 second. Okay. So my name is Blanca Contreras. I am a transplant outreach coordinator for UI Health. And so here is what we are doing at UI Health. We're very proud to be able to have a highly experienced surgical team. We take on a lot of complex patients. We have transplanted frail patients. We have a specialized muscle therapy program. We have transplanted patients with calcification that have been denied at many other centers. We have an expert vascular surgeon that is able to take care of those patients. We have a transform clinic specializing in our obese patients. So they are given options for both medications or bariatric surgery options to lose weight and be able to get transplanted. We have unique robotic options for those patients with high BMI. We have leading nephrologists with national reputations for innovation that have been doing a lot of different research projects within our transplant program. We also offer a Spanish language clinic. We know that in the Chicago area, we have a high Latino population, so we're able to offer those patients their visits in Spanish with our bilingual team. We do have the largest simultaneous kidney pancreas transplant program in the country currently. And then we also have a living donor program. We have dedicated nurses and social workers with the goal of completing both the donor and recipient workup in 6 weeks or less. We have a formal education program for this. And then we're also partnering with the National Kidney Foundation, where we have a program coming up called the Big Ask, the Big Give. And this is more information on how to find a living donor. This program is happening November 22nd. It's a virtual program from 10 a.m. to noon. The QR code is right here. Feel free to register if you're interested. It's a really great program. There will be patient speakers. So feel free to register. And then my contact information is there if anybody has any questions. Thank you so much, Rachel.
No, thank you so much, Blanca. And now I am so pleased to turn it over to our panel. So Dr. Kolowski, Nadia, Jackie, Dr. Obaidi, it's all you guys.
Awesome. Well, thanks for having me on board. I'm pretty excited. And I do want to say thank you for that awesome CKD dietary talk. That was very informative. So appreciate that. Hey, Jackie, what's up?
Hey, not much. How are you? And thank you again for everyone having me as well.
Thank you so much, Dr. Kowalski. That was really nice of you. Appreciate it.
Yeah, diet, I think, is one of those things that we, as nephrologists, kind of skim over because we just assume a dietitian's going to take over and then we never send the referral to the dietitian. So then it's like, well, what's going to happen? So it was much appreciated for you to go over everything.
Yeah, I did appreciate it too. And I'm glad that you mentioned that. And just as a little plug, nutrition counseling is covered if you do have kidney failure, if you're a Medicare patient. So you can send a referral, or the patients can actually be a little proactive and actually ask you for a referral as well. And it is covered by insurance. So it's a nice way to be able to connect with the dietitian, get a little bit more guidance, and not worry about it, being out of pocket or an expense.
So is it only for like ESRD patients, or could it be for advanced CKD also, like 3B and below?
Yeah, so it's for CKD. It's actually starting CKD stage 3 through 5. Once you're on a treatment, like if you're getting dialysis, usually a dietitian is part of your team there. It also covers diabetes. So even if you have diabetes and you want to prevent, obviously, complications, you can even get insurance to cover a dietitian visit with diabetes as well. So diabetes and kidney disease are the two disease states that actually do provide coverage to obtain nutrition guidance.
It's a match made in heaven.
Yes.
Just kind of wondering if anyone has any questions, or else I'm going to start throwing some questions at random folks.
Oh.
All right, while we're waiting, I actually have a question because this came up when I was seeing a patient. So feel free to dive in, whoever wants to tackle this one. So we had this awesome lecture by Dr. Obaidi. dietary issues, CKD, and I'm going to focus on the first half of it, actually. So you were talking about potassium and all of that. Now, a patient once asked me, so am I not allowed to eat fruits and vegetables because they're healthy and they also have a lot of potassium? So I'm kind of stuck between a rock and a hard place on that. And I did share my answer, but I kind of want to know if there's more that I could have said too. So I'm going to throw it out there to you guys and see what you have to say.
Dr. Obadi, do you want me to go first?
Sure, Jackie, please go ahead.
Okay, are you sure? Okay.
Yes.
So, when I look at a patient's diet, most patients do not consume fruits or vegetables at all in their diet, or if they do it, it's in very minimal amounts, maybe one piece of fruit a day, if that, or once every few days, maybe a vegetable at dinner. So for me, I usually like to target, and we know that processed potassium, which Dr. Obadi did a great job saying, it's in a lot of our food sources now. We do need to look at the ingredient list to see if there is a processed potassium in that product. And those are the products that we target first. So we always target the processed potassium in a food. If the processed potassium is there, we usually look for alternatives. If their diet is pretty clean and doesn't have a lot of processed additives in it, and a lot of times too, when you think of foods, usually in the freshest form, it contains fiber that also is going to help decrease the absorption of that potassium. So usually processed potassium, you actually absorb that at a much higher rate than you do in natural sources that are in fruits and vegetables. So once we clean up the diet, get rid of a lot of the processed potassium, we then include fruits and vegetables up to 5 servings a day, which is allowed. That is the goal. If they are still struggling with potassium with that, we usually then can choose more lower potassium food items compared to the high. And so really it's an individualized approach. A lot of times we could do things too, if say culturally beans are a huge part of their diet and they don't want to give up beans. I know that's more, we can do things like soaking. We can do things like, cutting potatoes in small pieces, again, soaking or pre-cooking to try to get some of that potassium to be lowered so that they can still enjoy these foods. Do you want
Dr. Obadi, you want to chime in?
Yeah, I mean, I think for me, it's not never say never, right? So I think people should ingest fruits. I mean, not all fruits are good with high potassium, but there's other alternatives like apples and, grapes and things that they could definitely supplement with. So I always go like, no, if you love fruits, that's good. But again, moderation is key. And we usually have like a pamphlet that has low potassium fruit containing items. So they can always, instead of having watermelon, they could do, like apples or something. And usually it works out. We don't want to deprive someone of something that they enjoy. So even bananas, I know we do a wrist slap every time, no, don't do bananas. But someone who loves bananas, like instead of having 3 bananas or 2 bananas a day, you can have like a banana a day. It's not gonna affect you. So we do work with not really depriving someone, kind of working around what's available and going from there. I think that always helps because it is challenging. It's a lot of restrictions, a lot of medications. The last thing we want is to really restrict someone's quality of life and enjoyment. And so if they can, supplement with something that they enjoy just as much, why not?
Yeah, and I'm glad that you brought up portions because portions are important, right? So we do have a lot of low, medium potassium fruits or vegetables, and we just need to be careful of portions in general. So usually we can tend to get some to fit if they're even high, and then just substitute, like what you mentioned, with lower, medium options, still portion controlled.
Sounds good. Now, I'm going to piggyback off of this one because this goes into another question that I received same day, different patient now. So when I usually talk about eating whole foods as much as possible, I always talk about, hitting the periphery of the grocery store, right? But more and more when I think about it, and I realize that maybe not all of my patients are able to do that for various reasons, right? Either the grocery store doesn't have adequate enough fruits and vegetables there, they're older. It might be a monetary issue, it might be a whole bunch of factors. So if that can't happen, what would be the recommendations then to still obtain a healthy diet, but you have to utilize more of what's within the grocery store as opposed to the periphery?
So if you're mentioning more about fresh fruits and vegetables being too expensive and cost prohibitive, um, frozen fruits and vegetables are totally acceptable. Canned fruits and vegetables can be applied. So if you do frozen vegetables or fruit, it should not contain any extra stuff in it. It should literally be just the fruit or the vegetable, meaning it shouldn't have extra seasonings where the sodium will come into play, or extra sauces like cheese, where again, it's going to be higher sodium, higher fat. If you're using a canned product, again, if it's lower sodium, a lot of lower sodium products will contain a potassium additive. So we have to look at that. So you're going to have to balance the sodium and the potassium. I would, if it does have a potassium and you need to be potassium restricted, I would almost go with the regular product and then just rinse them. Same thing. It should not have any additional seasonings in there, no additional sauces.
Awesome, thanks. And then rinsing, right? I mean,
Rinsing.
rinsing was a big thing. You know,
Yes.
can you at least eliminate some of that? So awesome.
One
Thank
of
you
the
so
things
much.
I'd also like to say, Dr. Kowalski, for those people who have that kind of situation, if they have to buy like the processed foods, like Jackie was saying, such as the lunch meats in the packages or the hot dogs, whatever, the best practice they can do is like the soaking overnight would help it reduce that sodium. And not that it's the best thing to do, but I mean to eat, but if you soak it overnight, that does reduce that sodium content of it.
Good point. Good point. And question did pop up for you, Nadia. So ready?
I'm
So
ready.
what are some of the things you personally do to live well with diabetes? And also, how do you keep on top of your health while balancing everything else that life throws at you?
Okay, I'll go with question number one first. So one of the things I do well to keep up with my diabetes is and kidney health at the same time is portion control. I am a member of WW, and they teach the same. They have start WW and my diabetes nurse are on the same page, and they do. I can have what I want as long as I do it in moderation. So they have not restricted. When I first became a diabetic at 19, everything was no, 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 no. And when they did that, they realized that was not the way to go for me as a diabetic, because as a person, as a human, when you tell a person they can't have something, that makes them want it more. So they realized that was making a bad decision, because every time they told me no, that means I was going out and eating it. And WW realized the same thing. When they were restricting people from having things, they made them want to eat it more, and people were gaining weight instead of losing it. So when they revamped their whole science, my diabetic team revamped their whole science and said, you can have this, but do it in moderation. So have a portion of this, have a portion of ice cream, have a portion of cake, have a portion of this. And when they started doing that, I just started wanting it less and less. So it started becoming a thing of, yes, I can have this, but I really don't want it as much anymore. So my decisions and choices became more healthier. I started wanting more fruits and vegetables instead of more ice cream and cake. I chose apples instead of this. I started ordering less of this and half of that. So portion control became my biggest thing. So actually, my meetings, they call me the portion control queen, because now when it comes to my measuring cups, I don't look at the numbers on there anymore. I can tell by the size of it, like by the color. So this color means this color means that size means that. And I pretty much have a good idea what size is what now, that I've been doing it for quite some time. And what was your second question?
Well, can I piggyback off the first one now?
Sure.
Because there's another one. So with these changes that you made about portion control, how did you go about it? Because I feel that that idea falls into a lot of other categories too. And using exercise as an example, right? It's either a lot of people go all in or they don't go in at all.
Oh, it's not all in. It was very gradual, because you can't just wake up one morning and say, I'm gonna portion out everything. Because that doesn't work like that. Because your body goes to like a shock. You just can't tell your body, we're just gonna eat a half cup of this. No, you have to gradually do. It's just like when you're starting to smoke. It's like when you're smoking and you smoke 5 packs a day. You just don't all of a sudden say, "Well, smoke 1 cigarette." It doesn't work like that. Your body's like, "Well, what happened to the 5 packs that we were smoking?" No, you gradually step down to it. So you gradually start saying, "I'm going to eat a little bit of this. I'm going to eat a little bit of this at a gradual time," and give your inner stomach time enough to say, "Okay, we're accepting the fact that we're eating less food." And once you gradually step your down into it, your body starts to say, "Okay, we're receiving less food." And then you drink more water as into it as well, because at the time you figure out, do you think you're hungry? You're really not hungry. You may need something to drink. You may be bored. We learn in WW, what is your hunger really telling you? Are you really hungry, or are you just bored? Do you need something to do? Or you just need something to put in your mouth? So you learn what to put in your mouth. You learn, put a piece of fruit in there. Don't just go and make a whole meal because you think you're hungry. Because then you go like, that was crazy. I would have made a whole meal because I thought I was hungry, and then I was not hungry. I made a meal for nothing when I could have just put an apple in my mouth. Which, come to find out, with my diabetes, it's just 15 grams of carbohydrates you need to put. Some peanut butter, a little peanut butter and apple. There's your 15 grams of carbohydrates for your snack. A little granola bar or something, some string cheese or things like that. So you learn to kind of maneuver, kind of listen to your body and say, what do you really want? Are you really bored? Go for a walk or do something. Really listen to yourself and what you really want, and don't just sit there and eat because you're bored.
And how long does it take you to, for you personally, that is, that for someone listening also, to become accustomed to that change in portion control before you move on to the next one?
About 4 weeks, because you got to give yourself 2 weeks to get adjusted to the program, and then 2 weeks for your body to say, okay, we're adjusted. So that's 4 weeks to be totally adjusted. And then once you get adjusted, even if you decide you're going to go back, you're going to say, if you fall off the wagon, as they say, your body's already adjusted, because you think you're going to put more into your body than what you think is not going to happen. Because your body's already accustomed to eating less, and you're going to try to put more into your body's like, I'm not having it.
Yeah, I
I'm
love
not,
what you
because there
said.
are days I think I'm going to eat more than eat more than what my eyes say just because I'm hungry. It doesn't happen. It doesn't happen.
And you got to give yourself grace, right? I mean,
Right.
you're going to
Oh
make a
yeah, we're gonna
mistake.
fall down. We're
Yeah.
human. We're gonna say, okay, I'm really, because you may miss a meal or something, or you may get up late for breakfast and you say, okay, I'm not having breakfast this morning. I'll pick it up at lunch. And your body's like, yeah, you may have missed it and got a cup of coffee or something. Because whatever liquid you whatever put in your body, your stomach will fill that up. And so I'll just grab a cup of coffee for breakfast and I'll just pick it up at lunch. When you get to lunch, you think you're gonna be hungry enough because you skipped breakfast. It doesn't work that way.
And so, how do you balance all of this with life throwing life stuff at you?
Funny you should ask that question. I'm a full-time caregiver for my mom, so I have to balance that with my life stuff of being a full-time caregiver. So it's all about scheduling. I schedule everything. So there's a time and a schedule for everything. So there's a time for breakfast, there's a time for lunch, there's a time for dinner, and I have to balance that with being a diabetic because she's a diabetic as well. So everything has to go in a 4-hour schedule. Making sure everybody eats at 4-hour intervals with no lag in between, so there's no dropping in the blood sugar. So everything has to go in 4-hour intervals.
Well, thanks so much for that. Dr. Lottie, I have a question for you. All right. Welcome to the hot seat. So many times in my experience, when I have patients coming to me for CKD evaluation, they're on a ton of medications already. And you presented very well about the benefits of some of these other medications that we have, whether it's Ozempic, whether it's, one of the SGLT2 inhibitors. I have met resistance with patients, and I'm sure every doc has. I just kind of want to know how you navigate that, I guess, that roadway, just to kind of let them know that this is important and it's not just another pill in your pill box.
Yeah, I mean, I think that's a great question. That's pretty, frequent that we see that a lot. But I think for me, I always put this front and center because I really do believe that physicians always have an agenda And patients always have an agenda coming into clinic. So I always try to, as much as I want to push these medications because I've read the data and I know the benefits, I always try to listen to the patients really, like what are their goals? If their goal, for example, is to optimize sugar and they have a strict diet plan, they're going to talk to the dietitian and they really are motivated, then I kind of retreat because they clearly have an agenda, they have a plan. And who am I to barge in and throw in a GLP-1? And I've done that before, but it always is met with, you don't believe me, or I need some, someone to cheer me on. And so I always learn to listen. And if patients have a concrete plan that, hey, just give me a couple of months, I really want to work on my sugars, I really want to lose that weight, just give me 2 months and we'll come back. And it's just the idea of planting a seed, right? So all you need to do is, there's these new medications. I know now is not the time. I hear you. I see that you want to lose weight. I'm with you. I'm really motivating you, and we'll address it. And I usually put a small note in my, note in my notes. It's like revisit on next visit. And usually sometimes the next visit, they bring it up. It's like, hey, Dr. Beatty, the weight plan did not go according to plan. Let's do GLP. So sometimes they initiate it. So and sometimes it's really a matter of working with these patients because I'm not there at home seeing them take all their meds. Who am I to keep adding, like you mentioned, all this polypharmacy? And so I work with them. The other thing is sometimes if I really do feel like this is a pressing need because the proteinuria is like 2 grams and they're gaining all that weight, I really do have to be paternalistic and really push that agenda because, I don't think they're going to lose 20 pounds in 3 months. I usually, partner with them. It's like, hey, I'm going to take out one of your meds, whether it's amlodipine or something that's a minimal dose. I'm going to take it out. I'm going to put lisinopril on board. I'm switching out. I'm not adding anything new. Let's switch something. I think it's better for you. I'm not adding more. I'm just switching. And so usually they go like, okay, fine. If it's not increased pill burden, then they're usually okay with it. So working with them on optimizing their current medicines because you have no idea how many times I've seen patients on hydralazine, for example, for blood pressure and CKD, or nifedipine when they should be on an ACE ARB at least to begin with. And so I always am mindful of that, medication list and to see what are some things I can switch out that are more kidney, like 2 birds, 1 stone, especially if they have heart failure, CKD, diabetes. 3 birds, 1 stone, right, with GLP or SGLT. So I do make that argument, and usually I don't feel any resistance because you're not increasing pill burden per se, but you're supplement or you're switching something with another thing that's more beneficial.
I love that approach. I really do.
Thank you.
I don't think we do that enough. I feel, and I'm guilty of this too in the beginning of my training, where we put ourselves on this pedestal that we know more than everyone, and then you slowly realize that the more you know, the less you actually really do know, and then it just kind of brings you back down to reality. But
It
I
really
love your
does.
approach.
Thank you.
Jackie, I got a question for you because this popped up too, and this is also something that Dr. Obadi talked about. Okay, so she made a couple references in her dietary talk about how some medications can cut down on inflammation, to say the least. What would you advise if patients, want to start taking additional supplements that they read online because it's supposed to cut down inflammation here or there, and it doesn't even have to be, the rarity that they pick up in some weird, pharmaceutical, hole in the wall joint where it comes in a little baggie. I mean, it could be something just like omega-3 fatty acids, let's say, right? What would be your recommendation for them?
So first, to decrease inflammation, of course, with me, I always like to go food first. So the big thing would be try to get their diet to be as clean or as natural, less processed as possible, because we know that less processed foods going to decrease the inflammation. Also, maybe they're not eating enough fruits or vegetables or whole grains. We can kind of do that, or fish as a way to get natural omega-3s in. I also do like to listen if sometimes people feel better if they take like additional supplements, right? They feel like their diet is lacking something, so they want to add something in. The first thing is just always make sure that it's safe. It's a certified supplement. It has a label. It's coming from a reputable manufacturer. The next is to check with the dietitian or the pharmacist or your nephrologist or your, primary care to make sure that it's safe to go with all the other medicines that you are currently on, because there's a lot that have a lot of interactions that you need to be aware of. It may enhance the medicine or it may decrease the effectiveness of some medicine. After that, I usually like to work with them, right? So if they want to add turmeric or cumin to their, smoothie in the morning just because they feel like it's beneficial, as long as it's not harmful, that totally can be done safely.
I love it. I love it. I think that's probably the biggest one that's missed is the interaction with the medications. Everyone thinks it's natural, so it's not gonna harm anything. It's just gonna make us better. But yeah, there's a lot of stuff out there. So thanks for sharing that.
Sure.
Yeah, and I think I actually had a patient who came in concerned for chronic kidney disease, and I think it's very important to intentionally ask if patients are taking any supplements, because I just happened to ask, "Hey, are you taking any over-the-counter supplements?" And she did mention that she was taking lithium daily for inflammation. And I was like, well, probably not the best supplement to use. And so
Wow.
as soon as we stopped lithium, creatinine came down and everything came. And this was actually prescribed by a nurse practitioner out of state. So this is actually being prescribed nowadays by, it's always humbling to hear these stories and to elicit, like, no one's going to tell you they're taking supplements. It's a kind of a sensitive subject, but I'm always very surprised with the amount of supplements people take without even disclosing them as part of their med list. So always good to ask, for sure.
Or what they feel like, their friends might have said, "Oh, I heard the supplement helps prevent kidney disease. Why don't you try it?" Or they Google it and they see all these supplements that are supposed to be kidney healthy or protective that truly aren't. So there are good resources. Definitely reach out to your primary care nephrologist if there's any doubt. I always say, just tell me anything. If it's safe, I'm okay with it. I'd rather look it up and know that it's safe for you rather than you not sharing, and taking it on the side.
Yeah, 100% to both of you. I think that integrative medicine is becoming trendy now, and I see a lot of people now taking a lot more than when I first started practicing. So I wanted to throw that question out there. So, here's one. And I guess this goes to both of you too. And Nadia, you could probably even chime in on this one. I frequently have patients asking me, "Oh, I know I have CKD," or, "Yes, my primary told me, but, I'll take care of it. I'll drink more water. I'll flush everything out. I'll rehydrate it," kind of like you're going to rehydrate a potato or something. Is that even possible? I mean, can we just kind of talk about that now for a minute?
Well, I'll be the first to answer, and then I'll let the professionals answer. No, you cannot just flush it out. It just doesn't go away like that. If it was that easy, then I would have flushed mine out a long time ago. I know the best way to take care of the CKD. Depending on your levels, it can be reversed to a certain extent, because I did with my weight loss and proper taking care with proper diet, take care of mine from 3 to 2. And with proper nutrition and losing weight, it can be reversed to a certain extent, depending on what your levels are. But it has to be strict. So, like, I don't have any sodium in my diet whatsoever. I don't eat anything with salt. And when we were doing my kidney class, the people in my class were like, "You're kidding." I'm like, "No, I like eat low or no salt potato chips, or don't eat, if I eat French fries, there's no salt on them or anything." I've come to live like that. I like eat no salt pretzels. They're like, "What's the point?" Look, I'm accustomed to that. I've been like this for 11 years. So, and I'm always at stage 3. I did lose weight one time and get to stage 2. I had some problems and wound up at stage 3 again. But I do drink a lot of water, but I can't just flush out my kidneys and go back to stage 2 again. My nephrologist would love to be that would happen. What you have to do to take care of your kidneys, though, not to progress to another stage, is to stay on a low or no sodium healthy plan. Eat like you're supposed to, like Jackie says, not a lot of processed foods, healthy vegetables in your diet, exercise, stay on a plan where you're drinking water, And that's to keep you from progressing from whatever stage you're in. So you can have healthy kidneys, whatever stage you're in, but no, you cannot flush it out and just be gone completely.
Anyone
Yeah,
else?
that was beautifully said by Nadia. So I think I usually say the same thing because a lot of people drink fluid to flush it out. And I usually use the analogy, like you imagine you're a boat full of water. And, we usually put them on Lasix or a water pill. And I was like, Lasix or Bumex is a bucket trying to get water out of that boat. And if you keep adding water to the boat, what are you doing? And then it's a light bulb. It's like, oh, okay. And I was like, please stop drinking water to flush it out. And so I think, I think there's a lot of misconception as to what chronic kidney disease is. And I think the more you can approximate what we're dealing with and to break down this jargon to make it easily digestible and understandable, then patients usually partner with you. I think there's a lot of it is to do with misconception or not being informed the right way. And so I use analogies a lot, and I feel like it really hits the message home. And they always comply with their fluids, and they always tell me, they show me the logs, and I do see improvement in their edema or their condition. So I do believe in patient education really goes a long way to help bridge these misconceptions.
Thanks. And Jackie, do you have anything to add on that?
No, I would agree. I think patient education, right? Because sometimes people need to be restrictive in their fluid. So they can't, if they're retaining, they can't flush anything out if they're holding on to it, especially if their diet, again, like your analogy, if their diet is high in sodium, that sodium's going to just hold on to more and more of that water like a sponge. So it's going to keep adding. And I also hear a lot, like people who are diabetics, they'll, I don't really like juice. Anybody that, I'm not a big fan of the fruit juice or juice, but patients will always tell me, well, I dilute it, so it's fine. It's no more sugar in it because it's all diluted. Well, you just change the concentration. The sugar amount is still there. So you can't really, like to Nadia's point, flush things out like that. So working with them. So find something that does work.
Well said. Well said. So just to kind of summarize, I think the big take-home points right now are ask questions, right? Don't be afraid to ask questions. And whatever you come across the internet, I mean, stuff's recycled, stuff's old. Just ask questions. And I think that's the biggest one. And I think Dr. Obadi did it best, where she's just like, talk to them, befriend them, and, don't force things on them. Just kind of let things happen naturally. I think those are really good points. And Nadia, you brought some really good points up too. So I just want to say thank you guys for everything. Thank you for that wonderful lecture again. Thank you for chiming in and answering these questions. So hopefully, we can get this info out there and we can start breaking some of these myths.
Head on. Thank you, everyone. This was a pleasure. Thank you so much for inviting me today.
Thank you for having me today.
Yeah,
Thank
you.
Thank you all so much for joining us today. We really appreciate your time and your insight and the knowledge that you shared. And thank you to all of our attendees who joined us as well. I thank you all and hope that you have a great afternoon.
Same to you guys. Take care.
Okay, take care.
Thank you.
Thank you.
Take care.
care.